Thank you everyone for coming and joining this session today. I'm going to review importing CT scans and creating structure sets. I come from the Medical College of Wisconsin in the United States. I'm an associate professor there, and I'm also the director for advanced care and technology in the department. I just wanted to acknowledge Justice Adamson from Duke University for helping put these slides together. I got a little dialogue that popped up about asking me about translation. So
All
here's
right,
the
you can
outline
proceed.
for what I will review today. I'm going to go over the initial CT simulation process, including the patient mobilization and the CT scan parameters. Then we will proceed to importing to the treatment planning system and the steps that are taken there, assigning the CD to ED, defining the external patient contour, defining the treatment couch. We'll review supplemental imaging for target and OAR delineation. Includes diagnostic scans, 4D CT, respiratory scans. And then we'll review image fusion and then defining isocenter and target delineation. So we'll keep coming back to this slide just as a reference as we step through the process, but this is the basic workflow. So as I mentioned in the outline, we'll start with the simulation process where we'll acquire this 3D scan. From there, we will transfer that scan into the planning system. We'll define volumes for the dose calculation. If available, we'll import other images from radiology or other scans that we collected at the simulation. We'll have to fuse those to the scan that we're going to use to calculate dose on. And then finally, we're going to use those scans to define targets and organs at risk, and to find isocenter and the relationship from that point to maybe a reference point that we placed at the CT scan. So I'll keep referring back to this as we proceed through the presentation so everybody knows where we are in the process. So the step one here is the CT simulation process. So as I mentioned, we're at this first square. So what we have here is a picture of a CT scanner at one of our sites. And I just wanted to review the layout and some of the equipment that we have in the room. I didn't realize some of these things were movies. So let's start out with just in general, this is a CT scanner. It's a pretty standard Siemens CT scanner. You can see on here, there's internal lasers that project and they're integrated into the CT scanner. There's also external lasers. You can see these. In our system, we have them positioned about 50 centimeters or about a half a meter outside of the CT bore. And we use these to mark the patient, to align the patient, to set ISO or any other references. Ours are motorized, but in principle, you could probably also get away with a fixed system, especially if you're not defining isocenter at the time of sim. We also would like to point out that the couch on our CT scanner is flat because our treatment couches are flat. So this is where we differ from radiology. Radiology typically has a curved couch. We will have a flat couch in our treatment units. We do a lot of contrast injections for certain scans when we're trying to identify certain vessels. The other thing that we have in the room is an oven or a water bath, and we will use this to help form masks or other thermoplastic devices that we may be using. Our site, we in the past we've used what was called an alpha cradle, but basically it's a polystyrene cradle. But we stopped using those. We prefer to use vac fixes that are reusable and we can wipe them off. So you'll see here we actually also have a vacuum pump, which basically just sucks all the air out of this bag, but it's very helpful in repositioning a patient. And we normally index this to the couch. And you'll see on here the couch has all these various index marks, and we'll make note of that. I put some other equipment on the table just to give everyone an idea of what we use for simulation, but often for head and neck patients, we'll have a head and neck mask with a headrest. If it's in the abdomen area or the pelvis, you'll definitely see us using these vac fixes. We find that knee bolsters are very helpful, especially to minimize the gap in the lumbar spine region to the table, and it provides patient comfort. So this is in general an overview of the room. I did want to highlight two other systems. I'm going to spend a little time talking about the respiratory tracking system. So you can either use a camera-based system that uses a visual feedback or a respiratory tracking system. At our site, we predominantly use this respiratory tracking system, which is just a bellows around the patient to do that. But that's only for the cases of thoracic or abdomen that would have larger motion that you might be concerned about. So I think when preparation for the simulation is probably one of the most important things that need to be done. You need to identify the proper immobilization devices that you need, as I mentioned in that previous slide. And I want to highlight this, but consistent patient immobilization is extremely important. And you can get a great scan and it's very accurate, but if you can't set up the patient that way every day, it doesn't help you out in the long run, because if the patient isn't the way you expect them to be, then the dose calculation could be erroneous. So the other thing that needs to happen even before the patient arrives is you should determine what patient position you're going to have that patient in, depending on the treatment site. So I just recommend thinking through, if you're going to treat an abdomen, do you want the patient's arms down? Probably not. So you would have the patient position their arms above their head and get it out of the treatment field so they don't interfere. The other thing is localization points. So in general, it is very helpful to place localization points on the patient. Sometimes these localization points can also be the plan ISOL center, but oftentimes they're not. In our clinic, we like to use a steel BB or a couple of steel BBs, usually 2 to 4 millimeters in diameter. A BB is basically just a little metal ball. And at that point, we'll either put tattoos or removable marks on the patient that we can reference to when we bring the patient back to set up. In our clinic, we call those a 3-point BB or an AP BB. If we're treating breast or something where there's a lot of soft tissue in the area, we try to identify at least one BB, perhaps on the sternum, where we can reference to set up the patient in the future. The planning ISO center can be placed at CT Sim if you have a motorized laser system, but in our clinic, it's pretty rare that we place it at Sim. We usually do that in dosimetry, and we just place those reference points on. So the 3D image sets from the CT simulator. So what can happen at the time of sim is we can actually collect multiple CT sets, but the key to note here is that we only need one planning CT that we will rely on to do the dose calculation. And that one is very important that we know and we can control very specific things. Obviously, you want to make sure that the tube voltage doesn't vary. The tube current is less important in that setting, but you also need to know what impact other imaging settings might have on that planning CT prior to you using it to do dose calculations on. So there are the other scans you might collect might aid in target delineation. For example, I would recommend you get a separate scan before you put contrast in. So you would have two scans, one scan without the contrast and one with, so that you don't have to override all the densities of the contrast in the patient. This would save you a large amount of time. Down here, the main key to this, the two take homes is when that planning CT you acquire, it needs to have an accurate Hounsfield unit so we can do an accurate dose calculation. And we also need to make sure that the geometry is accurate and it's going to match the treatment geometry on a day-to-day basis. So best practices, and this is a good one, is just to keep it simple. Create and use simple subsets for RT-specific protocols. Again, don't change the tube voltage, the kVp. Make sure that gantry tilt is set to 0. A lot of CT scanners do let you adjust the tilt, and that's not going to work. Most planning systems do not accept a CT scan with a non-zero tilt. And then beware of the field of view being truncated, and this could be circumvented with maybe a new calculation, a reconstruction with an extended field of view. So I included this slide here, and I've also included a reference on my department website. We actually publish our CT SIM protocols. So I put an example on here for you guys to reference in the future. But we find that these CT SIM checklists ensure that you have a robust, high-quality CT image for planning. They help with setup, scan localization, give some guidance on the CT prescription, and then also for the planning CT reconstruction, what settings should be used and things that should be checked, extended field of view, for example, or metal artifact reduction. And you can see here, there's very basic things. If we're going to use oil contrast, our therapists actually use these checklists and they step through. We also have things in here, for example, in the pelvis, we should include the L1 vertebral body through mid-femur just to make sure we get enough scan range. So if we're going to include, for example, lymph nodes in the pelvis, that we include all the lymph nodes we might need to contour. So we find these to be very helpful. We also have a general idea of what presets to use for image metal artifact reduction, and then image contrasts that follow the manufacturer guidelines. So we actually just put these right here on the reference sheet so that the therapists don't have to look for them every time they need them. But we have examples of these on the website if you guys, for most of the major disease sites, if you want to take a look at them there. I did mention that the CT simulator QA, we need to make sure that we do not have gantry tilt. And as I mentioned, many CTs can be tilted for diagnostic scans. And I know a lot of sites share T scanners with radiology. So it is important to make sure that that's verified before you use it if you are using a system that does have that non-zero tilt. And I gave a reference here of TG66. They recommend verifying this with film. It's actually pretty easy to do with a CT scan. Most software will let you draw a vertical line, and then you can compare the vertical line to, let's say, a phantom. We have a plastic phantom that sits vertically on the table, and we use that to reference that it's level or not, and that helps us to confirm this. The other thing that I find is useful is
Douglas.
Yes.
Yes, there is a question in the chat from Suresh. Does using the artifact reduction changes the Hounsfield unit of the normal structure or not?
So metal artifact reduction will alter the Hounsfield units, but I recommend for your physicists to get comfortable with that. This particular algorithm, depending on the algorithm, we find helps to reduce that artifact. And we often have, for example, with dental implants, we struggle because most people don't know what their dental implants are and have poor records. So in those instances, when there's uncertainty in what the metal is, we find that just using the artifact reduction algorithm provides a better estimate than if we were to just guess what the material is made out of. So I think one needs to use some judgment in these cases. We've gone through these and we have a pretty good idea of the impact that they have. If something is going to be closer to the target, we might force the density in that area and just use it for target delineation. But it definitely will have some impact on that. And it's important that you understand the impact that your IMR might have on the Hounsfield units. Excellent question. Thank you. So another one that is extremely common in our clinic is oftentimes there's advantages of having a smaller field of view. You can increase the resolution of the targets that you're looking at, but you want to make sure that the field of view isn't so small that it's clipping your target. So in this case, if we were going to treat, let's say, this vertebral body, if the scan is clipped here, this would be problematic. This would be missing the tissue that would be used in the dose calculation. Most CT scanners support a retrospective reconstruction, in which case you can take the raw data and reconstruct it after the fact. So I recommend before the patient even leaves the room, it's always good to do a field of view check. And you can see that we have this usually on our checklists. Right here, a SIM field of view check. We'll run a CT scan, a very quick CT scan, just to make sure that the patient is centered properly and that we're not clipping any parts of the patient. The more common things that get clipped are usually like the arms or the elbows or things like that. So just be cognizant of that. Obviously, you don't want to have tissue deficit when you're doing dose calculation.
I think that brings us to the question here in the chat box where Elizabeth has asked if you can apply the extended field of view post-scan or before scan.
Yeah, most scanners will let you do it after the fact. So you can just create a new reconstruction with the raw data and do it after the fact. There are exceptions. So the field of view will have a larger, there's two ranges. There's usually a standard field of view and then the extended field of view. If the patient is being clipped outside of the extended field of view, there's nothing you can do about that. So you might have to get creative. In those instances, you should maybe have your dosimetrist or physicist come and take a look at the scan and make sure that having that clipping is going to be a problem. So there's sort of a yes and no to that. But as long as it's within the extended field of view, you can do it after the fact. So some considerations when sharing a CT scanner with radiology. Ben, I think I'm getting a little feedback here. So there are concerns when you share a scanner with radiology. So we have different priorities than radiology does. Radiology, our department, radiation oncology, the main things is CT number accuracy and spatial accuracy. Okay. We just need to make sure that radiation and oncology specific QA is performed on the CT scanner. And the recommendation is we should really check that on every time we use the scanner. If it's getting shared during the day, obviously you want to make sure that the Cantry tilt is 0 and all of these things that we've addressed. But you should also, at least daily, according to TG66, it's recommended to check the Hounsfield unit constancy, since we're using that to calculate dose. So once we have a CT scan, at this point, there's a couple of things that need to happen. We're going to review the CT to ED file and then what contours we need to use for dose calculation when we import this to the treatment planning system. So here we are in the process. We're on to this second figure now. So when we import the planning CT into the treatment planning system, really the CT scan is a collection of a bunch of individual CT slices. And those CT slices, when you stack them all together, create this 3D volume. So if you actually look at the raw data, these are all individual DICOM files. There's one file usually for each slice. And then each slice has its own CT slice number. And then when the planning system pulls them in, it pulls in all of these slice numbers. So the planning system will then have the ability to reconstruct this in a three-dimensional volume. So what the planning system does is it'll suck in all of these CT scans and then generate this 3D volume. In the process, though, we do need to convert the Hounsfield units on the individual pixel intensities need to get converted to an electron density, or in some planning systems, a mass density. So we'll pop onto this. So once we've imported that, we import the planning CT into the treatment planning system. You have to keep in mind that patients might have multiple courses under a single or multiple imaging studies, and you might be able to take a single CT scan. Let's say if you're having to treat a T-spine and a hip, you might be able to do that under the same CT scan. They might be separate imaging sessions, so you just need to be cognizant of that. It's important to name for you to name these in a consistent manner so that you don't get these sites confused and accidentally take one for maybe an older point in time that doesn't necessarily represent the patient geometry today. So that's an important step. Another thing I don't think I have it explicitly mentioned, but AAPM has a task report, TG263, that normalizes or standardizes the naming conventions for structures. And we find in our clinic that that's also very helpful when generating these. So just to familiarize yourself, so CT images are Hounsfield units, and the CT values are characterized by this. It's what's called the linear attenuation coefficient of the tissue, and this is the equation. So basically you take the linear attenuation coefficient of the material in a given voxel, and you subtract off the linear attenuation coefficient for water, and then you normalize that to water. So you're looking basically at a differential of how it varies from water, and then you multiply that times 1,000. And so you can see all of the different ranges of all the different materials on this slide. But ultimately, what we need to do with this is we're going to use this to determine what the electron density is. So Benjamin, if you have a moment, I'm wondering if we could take some of the scribble on the screen off. I don't think I put that on there, but here's some examples of a CT calibration curve. But ultimately, you're going to pull that CT set in, and you'll give it a name, and then you'll assign it to a CT scanner. But what you see here is, in this case, this is mass density, not electron density. But planning systems will be one or the other. And you'll have a Hounsfield unit that we mentioned there, and then the corresponding mass density here. And there'll be some sort of transfer function that we'll use. So then the system will look up a Hounsfield unit and then convert that to mass density, and it'll use that for the dose calculation. So the curve should be measured for your specific CT scanner and the information input in the planning system. After commissioning the TPS, the conversion process from the HU to density is usually performed automatically by the TPS. Usually the image continues to display the Hounsfield unit, but for the dose calculation algorithm, it uses the underlying electron density or mass density for the calculation. So in order to get that calibration curve, typically you'll need access or need to have access to a CT to ED phantom, as it's called, a CT to electron density phantom, where you have plugs of known densities, either electron density and or mass density, and you'll grab a bunch of CT scans and collect this information, typically with the image plane at the center of this phantom. And you'll create these curves that you'll refer to in the planning system. So the effect of the CT system on the CT to ED curve is important. So this is just a quick plot of a bunch of materials that we've grabbed and the different systems that we've had in our department with different tube voltages. And as you can see, in the region here where it's closer to water, for the most part, they're pretty consistent. But as you get higher, you can see that the impact that the differences in bone have on these different CT scanners will create some spreads on here. So it would be advantageous to make sure that you always double check to make sure that you know the impact that CT scanner has on this curve. And I think this curve clearly demonstrates that there's some differences that can exist. So I've got a poll question here, and Benjamin, I don't know if you can help me out with this. Can we generate a poll quickly?
Yeah.
Well, while you're working on that, maybe let's just go through this question. So can CareDose be used during a 3D CT for a treatment plan? So we've got four options here. So CareDose, for those that maybe have heard of this or not, is some scanners have the ability to modulate the tube voltage to account for heavier or skinnier patients, and also the tube current. So the premise of this question is asking us, is it okay to use that setting when we're going to use a CT scan for treatment planning? So when I'm looking at the answers here, the one I think I should have. So we do not want to change the tube voltage. So yes, but we wouldn't want to be able to change both the tube voltage and the tube current. What we could do though is we are able to change the tube current, but we don't want to change the tube voltage. And I'll go back to this slide so you can see that we've got an average for the two different tube voltages that are here, and you can see the effect that the tube voltage has. It does create a difference on the CT to ED curve, especially for the densities of bone. So in general, it's recommended to not vary the tube voltage when you're going to calculate dose on the scan. So there you go. So let's move on. So now that we have a CT scan that we have loaded into the system, what we're going to do is there might be other CT scans, either from radiology or from the CT scanner that we want to pull into the planning system. So let's take a look. First of all, the first thing that we need to do is we actually have to define a volume that the system's going to use for the dose calculation. And what you see here is this is a thoracic patient, and you can see this is a back fix on the side here. You can see the CT couch here. So what should be noted here is that the CT sim couch does not look in any manner what the actual treatment couch is. So you can see here, this couch looks very similar to a Civco couch top. And what often, most planning systems will ignore the density outside of this external patient contour. And so what we'll do is we'll end up inserting a couch that represents the actual couch and not the couch from the CT scanner, okay? The other thing is the 3D contour needs to be put on. And it's important that the 3D contour is accurate and it includes all of the tissue that you want to calculate the dose. If for some reason I were to cut off this, if I were to cut off this contour short, I would be actually missing the attenuation of that tissue, which would be problematic. We wouldn't want that. Okay. So other diagnostic imaging sets, they may include a PET scan, a positron emission technology, a CT, an MR, and they might come from your hospital or clinic, or they could come from another one and they're getting sent to you. So the purpose of these scans is different than the one that we would use for treatment planning. So we are only going to usually use this for target definition. Occasionally, you might use it for an OAR definition. For example, if you're going to treat a vertebral body and you want it to a higher dose and you wanted to maybe spare the cord, you wanted to know where the cord sat in the spinal canal, things like that. So at this point, we're going to use the sort of spatial information and transfer it onto our scan. That's sort of the purpose of these. They're imported into the planning system, and we're going to fuse those. We are not going to calculate dose on these. Obviously, we wouldn't have a way to calculate dose on an MR since we don't have Hounsfield units. That's reflecting proton density. So we would have to have some system of converting those over. So I also wanted to include the case, and I mentioned that our system has a respiratory motion system. There's a lot of different systems out there. There's a spirometer, which basically quantifies the amount of air that's entering and leaving your lungs. Respiratory bellows, this is something that we use here, which just tracks, it's a surrogate of the lung volume. There's also an optical tracking system. Varian has something they call like this RPM system that uses infrared markers and a camera. And typically what happens is the 4D CT image is really a series of maybe 10 to 13 images that are collected at a given couch position. And then they get sorted into the different respiratory phases based on that surrogate. So you can see here, here's a couple of examples of the different phases and how these are collected. And I've included a reference here for you to look at. I don't think we have time today to go into too much detail, but you can see there is the table translation that's occurring at these different positions. And then you get, for that given phase, you get a shift. And we're tracking end inspiration and end expiration. If you were to take a phantom and take a look at this, you can see this is the phantom motion. This is the maximum intensity projection. And basically that is a CT scan that finds the highest value in a CT and basically identifies all the high points in those images and then creates a single image. This is what an average would look like if you took an average of all those CT scans, of those 10 to 13 scans. And here's a minimum intensity projection. So this is the only area where they overlap. So this image here would be great if you had a target, let's say in the lung that was moving and you wanted to identify that target. This one here, it would probably be a good scan to use for dose calculation because this will tell you where it is on average in a given point in time. And this one here that doesn't really have much value for radiation oncology. We typically don't look at these minimum intensity projections. So here's a couple of images that we have here. You can see this is the raw 4D CT scan that we would acquire You can see it's just a patient free breathing motion. Ultimately, you typically oversample during the 40 CD acquisition, but you end up generating about 10 phases that are all acquired simultaneously. And then each of the phase of the breathing cycle gets sorted. Here's what an average CT would look like. And an average CT tends to have blurred edges. The images maybe not as crisp, but this is actually a very good scan to calculate dose on. You could also use, this is getting more common in the US and Europe, is to do a mid position where you take all of these scans and you calculate the mid position of them. And then it basically represents both an average, but then a geometric mid position for that. Our clinic also has found that the 20% phase image does a pretty good job of representing where the average CT position is. So we use that from time to time if we have problems generating the average CT position. Our physicians will use the maximum intensity projection to help draw targets, especially in lung, but this is not appropriate for planning and dose calculation. So I want to stress that it would not be good to calculate dose on a MIP. And then finally, a free breathing. A free breathing scan, the key to this one is you kind of collect this scan in a very slow manner so that it blurs out, and it basically creates the equivalent of an average CT for you. Because if you acquire it slow enough, all of the blurring occurs during the acquisition. And this is another one that's appropriate for plan and dose calculation. Here's another example. You can see here, this is the 3D free breathing. Here's an average CT, so the target now looks a little larger. And then here's the MIP. So the MIP will always overestimate the volume. It's going to always be larger than the actual target volume. The 3D scan, depending on where you grab it in the respiratory cycle, it may underestimate the volume. So in general, the preferred method is going to be really the average CT. This will be second, and then never use this one. So what if the respiratory? Yes.
I really appreciate this concept. I personally have not been very much confident with this, for the CT, but the breathing or techniques and all that. But I must say you tried very much to simplify this, and I can apparently say that at least there is something I know there is some logic that I can explain behind why I should prefer this side of that and all that. So I don't know if any person in the online has any question to put forth concerning this, but to me it's very, very clear.
Well, if some questions come up, please stop me. I think I've got maybe another slide or two on the respiratory motion. I think the key to respiratory motion is having a good understanding of what it is you're doing. And I can probably send some other publications like on the mid position. That's something that we've started doing in the last maybe 5 years or so that we found is a pretty accurate technique. But what do we do then if respiratory motion is large? So we've got a couple of options. If you look at our protocol for our CT scan on the website that I mentioned earlier, so this is a good question. What makes a 40 CT a 40 CT? So that goes back to this. So what we do is we are actually collecting a scan, and what happens is between this respiration and this respiration, all of these little dots here are the points in time for one couch position where we collect a CT scan. And this is the surrogate, the signal of the respiratory wave. So every point we're collecting another CT scan and the couch hasn't moved. So we're basically collecting maybe like 13 times more images than we normally would, right? We oversample it a little bit. The scanner doesn't just collect 10, it actually collects a little more just in case the respiratory rate speeds up or slows down so you can get enough information you need. And by using this information, this signal, then we take each of these, and for all of these points here, we find all these same points, and that it becomes one respiratory phase. And then all the points down here at the bottom become another one image. So a 4D scan is actually 10 different scans of the same patient and each scan represents a different point in the respiratory cycle. And so the 40 CT, this is the 40 CT here. So you can see this, you can actually see all of the internal motion of the patient. And you'll see that some patients have a lot of volume in their lungs, and the diaphragm might move 3 centimeters, quite a bit. So if your target is on the smaller side that you're treating, but you have 3 centimeters of motion, it's good to have techniques in order to make sure you're not missing your target. So one option is to do breath hold. So we can ask the patient at different periods of time, and this works out pretty well for a 3D treatment. So if you have a patient that's healthy enough to maybe hold their breath for 15, 20 seconds at a time, you could have them breathe and hold to a position and then turn the beam on. And then after 15 seconds, turn the beam off and tell them to breathe again. Another thing that's pretty helpful, especially in that large case where you might have a patient who's breathing very deeply, is to put a compression device on the stomach. And in this case, this will help. And what it does is it causes the patient to breathe more shallow, in a more shallow manner. And that more shallow breathing will usually increase the respiratory rate, but decreases the amplitude of the respiratory motion, which is very helpful. And so if you look at our protocol, the protocol that on our website, we have a compression belt that goes around the patient. It's basically like a large respiratory cuff that we put around the patient's abdomen. And we'll put that around the patient loosely at the beginning of the scan. And if the motion is large on the CT scan, we'll actually inflate the compression belt and then take another scan. And if it reduces the motion, then we'll proceed with treatment with this in place. Obviously, this won't work if you're treating something in the abdomen because it has to sit over the abdomen. But if you're in the lung, this does a great job for that. And then the final option is the kind of our last resort, is to do a gated treatment. But this is going to require additional equipment on the machine so that you can take that surrogate and turn the beam on and off. The system that I had back here in an earlier slide, this is way back here, but we use this as an Anzai system. I think some company in Japan sells this, and Siemens sells it with their CT scanners. But this we're able to also use on our linear accelerators. You can send that trigger over. So let me get back to where we were here. So let's go to the next question. I apologize for I'm not familiar with the Zoom poll, so maybe this will be just a self-test for yourself. But what is not an acceptable abdomen CT scan that can be used for planning? So a free breathing scan for 40, as I mentioned, it might not necessarily be ideal, but it's usually very close to the average 4D scan. The maximum intensity projection, this is going to overestimate our target volume, especially in lung, and it may overestimate the densities that we're going to treat through. So this one here, this one probably would not be acceptable. And then the average CT, this is kind of your ideal. So in this case, the answer is B, maximum intensity projection. We do not want to be using that.
Yeah, from the chat box, I can see very many people are going in for the option B. So yeah, they got it right, most of them.
Okay, great. The next question, which scans can be used for treatment planning dose calculation? So this kind of references maybe a couple of sections ago. So I just want to make sure this concept is well understood. But option A here, 3D CT scan from radiation oncology CT scanner. Well, in this case, our physicists or dosimetrists should have a good handle on what the CT to ED curve is. So and we know that we have a flat tabletop, and we know that the gantry tilt is 0, and it's in a controlled setting, and we know it. So, but what are we going to do about an MR from radiology, or from a CT from radiology? Well, in that case, unless you know something about the CT scan from diagnostic radiology, like it's a shared CT unit, if it's coming from a radiology department and I don't know where I don't have any idea of what the CD to ED curve looks like from that CT scanner, I should not be using that. And an MR, well, an MR doesn't give us information to generate dose calculations. We can't estimate the electron density or the mass density from an MR. So we would never use an MR from radiology. There are some scanners now that will generate a synthetic CT off an MR, but again, that the one that we should be using in this case is the one from radiation oncology, and that unless you have these other systems well calibrated. So now let's move on to image fusion. Okay, so we've got those scans in, whether it's a 4D or an MR or additional CT scan that you might have grabbed. And now we have to bring all of those scans in, and you have to create what's called a registration object that links those two scans together. So you can see here for image fusion, when more than one volumetric image set is used for planning, we need to define the spatial relationship between the volumetric image set between the two. And you can see here, this is a simple blending tool that we're kind of going back and forth. You can see the planning CT and the MR. Now, one thing I should mention is ideally, it would be great if you could use the same immobilization devices when you grab the other scan. But that oftentimes that's difficult, especially if diagnostic radiology grabbed it. So what I typically see is radiology will grab a scan and they identify a problem. And then they call up radiation oncology and ask them, we need this treated. So we usually don't get another scan. So you have to remember that sometimes the scan might not be in the exact same position. I mean, in an ideal case, and if you can control it, it's great to get the same immobilization device, but in reality, it's not always possible. So when you do image fusion, do your best to focus on the areas that you're treating and understand those issues. So if you're gonna use that to define a target, make sure the image fusion looks very good for the target. If you're going to use it to find a specific organ, make sure that that organ is fused. And sometimes you might have to fuse the image multiple times to get the information transferred that you need. Okay. So there are different types of image registration. Rigid 3D, that's the case where you just rotate the patient around and get it to where it needs to go. There's a 6-degree rigid, there's a 3-degree rigid. So this is just translation. Moving it, superior, inferior, right, left, anterior, posterior, and moving the two images around. The other one is a 6-dimensional. This is probably the most common right now, and you can do the translation and the rotation, and you can usually get it pretty good. But in the instance when maybe you are struggling, let's say you have that case from radiology and the patient isn't in the exact same position, it is possible to do a deformable registration. But for this one, I would be quite cautious. Make sure that you understand how the algorithm works, and it's important for your physicist to perform some quality assurance to make sure that things look proper. You should maybe check a Jacobian and a curl and make sure that all of those parameters that when you do that calculation look reasonable. And there's a lot of systems that can do this, but always be careful. This is easy to wrap your head around, but deformable registration, it can do very unusual things depending on the algorithm, and you want to make sure that it's accurate, not that it's conveying incorrect information, especially when you're using it to define a target. So there's manual registration, and in general, this is often done just manually, blending between the two images, as I mentioned, and then manually moving them around. There's also a lot of automatic registration algorithms. Oftentimes, it's nice to get it close with your eye and then run the automatic to do some fine tuning. That's very helpful. So, but always just remember, keep an eye, like if it's this vertebral body here that you're keeping an eye on, make sure that's the one that's the most accurate if you're going to use it to define a target. And just use some common sense as you're using it. Another way is you can do multiple points. Planning systems will let you select points and then use those initial point alignments to create the initial fusion, and then you can make some adjustments from there. So this is an example of like a 3 separate point. We took 3 different points on the scan, on both scans, and then after we've identified the two, it will actually do a least squares fit of all 3 points to get them as close as possible to one another. So again, in this case, it's still a 6 degree of freedom registration, but instead of looking at all the points, you can use it to maybe pick some more prominent points on the anatomy to help repeat the registration. Another one is intensity based, and in my mind, this is very similar to your manual, but in this case, this would be more of an automatic registration where the algorithm would look at the 2 images and then try to use the mutual information between the 2 image densities to minimize the discrepancies between the 2 registrations. Image registration similarity measures. So there's a sum squared difference. This takes the raw difference between the intensity value on each voxel. It's appropriate when the intensity value should match absolutely, such as a CT to CT with the same settings. It's the most simple. We typically don't use this one very often. There's the cross correlation. It's great at comparing image volumes with the intensity values that are correlated but do not match absolutely. This is a good one, is like if you have an onboard cone beam system and you're trying to register a CT scan that you've acquired, this is good. And then I mentioned this one earlier, the mutual information. This one is probably the most robust and the most common, but it quantifies the amount of information obtained about one random variable through observing the other random variable. So this is more of a measure of entropy. It's great at comparing image volumes with dissimilar intensity values. So if you're going to kind of go between different imaging modalities, this is a really good one to use. So as I mentioned, be very cautious when you use this one. There's many different algorithms that exist when it comes to deformable registration, and they're very difficult to verify. So you want to make sure you have some tools in your belt that you can perform the QA on this. If you don't have those tools in your belt, I'd be very cautious. If you can't do QA, you can't check a curl, you can't check a Jacobian, you can't look at the deformation vector matrix, then I would probably shy away from this. But the results are, the registration can be prone to errors, and it's not robust to large changes in anatomy. Rigid registration is what is almost always used clinically. There are cases when people might use this if they have the appropriate tools and a good understanding of how it's being used. But again, caution should be used when using this. If it was me and I was starting out doing this new, I would start out with a 6 degree of freedom registration and manually do them, and then get comfortable with that. And then after you've been doing that for quite a few years, that might be a good time if you want to start looking at the deformable registration and see what's out there and what's good and what you can do, and make sure you have a solid understanding of how it works. There's a question here. Can you explain deformable and non-deformable? So just you can see here on this image, from day to day, what's happening here in the deformable case. A deformable will take individual pixels or voxels and shift them in space, and they will be shifted in space differently internally than other voxels. So you could have a neighboring voxel, one voxel here gets shifted way over here, and you can see this one's not getting shifted at all. So this will actually recommend just basically just stretching the image out, compressing it in areas. So it's very complicated how it does this, but usually it's trying to match densities from the 2 images up and trying to get them to be in alignment. So you could envision like the case of an abdomen, like where you had the liver moving up and down or in a different position, or the stomach was filled with different food on one day compared to the other. A deformable registration will try to match the external surface of the stomach up with the from day to day, and so you'll see some stretching and moving inside of the patient. And there's definitely different parts of this that are going to be more difficult to handle. Small bowel, large bowel, things like this, usually these algorithms really struggle with, so I wouldn't even bother in these sort of areas using those algorithms until better tools come out for that. We've got another question. What is your recommendation for BBs for CT ISO in the case of deep inspiration breath hold as moves while scanning? Additionally, do you have any insights on planning with VMAT for DIBH? While it may not seem practical, I would appreciate your advice and thoughts on this matter. So the excellent question. So deep inspiration breath hold, in our clinic, we mainly use it on breasts. In our center, we have it's called a SGRT, surface guided radiation therapy. Basically, it's a camera on the ceiling that uses a pseudo-random pattern of fluorescent light that shines on the patient, and it can calculate where the surface position is in time. Some clinics will use a respiratory belt and also use that in that sort of setting. But ultimately, what you have to do is get the surface to where you need. And in general, we tend to do those in the 3D setting. I'm not sure what scanner you have.
Mandara kudus, but andizokuti ndepapi. Catherine, do you want that?
I think we can proceed.
Okay. Additionally, so the VMAT ones for DIBH, I would find that would be pretty challenging for a patient because VMAT deliveries tend to be longer and you would have to interrupt the beam. So we find that the treatment time is prohibitive. It's prohibitively long for patients to do a DIBH VMAT. So we tend to, for our breast patients, do a 3D because we can treat them more quickly. I could easily, it would be, what you have is you would beam on for maybe 15, 20 seconds, but then they have to catch their breath, right? And then while they're you're basically have a machine that's sitting there doing nothing while the patient's catching their breath for the next series of monitor units you're going to deliver. So it's not always very practical to do VMAT, I would say. And in general, we tend to not do VMAT DIBH delivery, at least until we can come up with ways to improve the delivery time. It's a really big struggle. In deep inspiration, the CT ISO is placed in the free breathing or in inspiration. So actually at ours, we tend to, we grab two scans. We'll grab a DIBH scan and a free breathing scan. And we'll compare the two during treatment planning and what the dose distribution looks like to determine if a DIBH is actually needed or not. If there is benefit, and it's for us, there's usually, like, for example, a left breast. A left breast tends to benefit from having the heart a little further away from the chest wall. So in those cases, that works out pretty well. Also, if you're treating something internally and there's large organ motion, you might find that is also helpful. So in that case, you'll be able to, you can look at it both ways and then make an evaluation. And so the ISO would be just placed on whatever scan it was that you were planning to treat on. So now we've got image fusion. Now it's time to define targets and organs at risk, and then these points. So the volumetric image is different than the structure set. So normally in the planning system, you'll have a CT. Under the CT, you'll have a structure set. Under the structure set, you'll usually have a plan. And then under the plan, you'll have a dose. So you can have multiple plans under a structure set, and you could have, this is sort of the cadence. But at this point, we've got a CT, and we're going to generate a different structure set. And we can technically have multiple structure sets under one CT, depending on how your planning system is set up. So basically, what we're going to do is we have this volumetric image set, which is just the matrix of all these intensities that got reconstructed from those CT scans. And then we have the structure set, which is a target and organ volumes defined using this volumetric image. Okay? And you can see here, this is a good example. Like, you have the liver contoured here. It's very straightforward, and it's based on an intensity value. In the case of a target, we follow two definitions. ICRU is older, and it's been recently updated to 62. Basically, the big update in there is the addition of the ITV that includes some motion. But typically your GTV is gross, this gross tumor volume or gross visible disease is a good way, where you can actually see the disease on the CT scan. The CTV is going to include what we call subclinical disease. And this is the volume where we know that we might not see it on here, but we know that this is all connected. So the disease is probably already spread into this region. So we're just going to go ahead and treat that volume because the probability of this disease being here is extremely high. So it's a high probability region is what your CTV is, high probability of disease. And then the PTV should depend on the type of immobilization and setup technique, as well as what tolerances you're able to keep your treatment machine in. So this is setup, we call this the setup uncertainty. And you can see we have different margins depending on what we're doing. So the GTV is here. There isn't just an expansion of this, but usually the physician will take a look at this. Maybe they'll expand this out in a soft tissue, but in this case, it's all one vertebral body, so they wanted to include as much of that as they could, right? And then the PTV, this is usually physicists will work with the physician and give them some guidance as to what sort of expansion they should use for the combination of immobilization devices and treatment unit that they're going to treat it on. If you 62 also includes the ITV, which includes the target motion. So if you're going to plan on a MIP, that would be your ITV, and then you would add the margins on top of that. So defining organs at risk, in our clinic, this can be defined by a dosimetrist. Oh, I'm sorry.
Douglas.
Yes.
So I'm wondering, so is the PTV currently in the modern practice somehow determined by the imaging frequency? Is it somehow related? Because you realize that since you say the PTV is in most cases related to the setup and immobilization device that will be used during the treatment, and we have EBRT in practice. So does it have to change, like the margin that you give to the PTV? For instance, can you push it to like a centimeter, 1 centimeter from the 3 to 5 millimeters, and you go up to a centimeter? That's if you do not do a daily imaging, let's say, of doing the cone beam. So I don't know.
Yeah, so excellent question. So in our practice, it's become a function of the disease site and the immobilization. So if it's in brain and we have them in a head and neck mask, and we have a nice headrest in there that's comfortable, and the mask is quite tight, we might use like 3 to 5 millimeter margins on that expansion from the CTV. Now, if we move into the abdomen and the motion isn't too large, and we're treating a pancreas, we might use, a 1 to 1.5 centimeter expansion on the PTV. So we're making sure to include that margin of uncertainty. So I think if you do not do IGRT, your margin should be larger because you can't verify it on a daily basis. So normally what I do is I look at the IGRT image, and when I look at the IGRT image, I turn the PTV on, and I make sure that the GTV plus that margin that the physician, or basically the CTV, is going to fall within the PTV. And if it doesn't fall within, we either have to make an adjustment, or that is an indication that perhaps we need to replan it and increase the margin, right? So I think once you do enough of these patients, you'll get a feel for how small you can make your margin without canceling treatments. Because like ultimately that's your goal. Like if things aren't lined up, your option that day is to cancel if you can't line them up properly on a day-to-day basis. But if you have IGRT, at least you know if you line them up properly. If you don't have IGRT, well, that's a problem. I mean, you might be doing it with a portal image and doing external references, but in that case, I would err on the side of a larger PTV, right?
All right, sure.
Okay, so defining the organs at risk. So again, this might vary. I think in our practice, most of the time it's dosimetrists or physicists that are contouring these. Our oncologists will always review the OARs just to make sure that there's no gross errors. It's more of a safety thing than anything. But in general, we find that it's relatively straightforward to train people on how to contour the normal stuff. The abnormal stuff, that's usually set aside to the physician. There's a lot of information that goes into making the decision, labs and whatnot, that might also contribute to the decision of what needs to be treated. So in general, though, that's a physician. So best practice is to define a set of structures that are contoured for each site. And we've created sort of structure templates for each site. And I think TG 263 also would help you out, helping you identify what structures you need. I mean, obviously the physicians are going to know what they want to avoid, but it's good to contour them. And also when you get that CT scan, like let's say you're going to treat something in the liver and your physician wants to know what the dose volume constraint is for the lung. But if you didn't grab the entire lung, like if you only grabbed 4 centimeters on the base of the lung, your physician might not get the information they need, right? So just always make sure that your CT scans are big enough to include what OARs are in those standard templates that you're using. So contouring tools, for this, there's manual contouring tools. I think that everybody those are pretty straightforward. It's usually a paintbrush and you go through one slice at a time and contour your structure sets in. And then there's also a lot of automatic contouring tools that are out there now. There's threshold-based ones, machine learning systems, and things like this. This will depend on what planning system you have. My general observation is there's certain structure sets that these algorithms have become quite good at, but those are the ones that are very easy to contour, like a liver or a kidney, bone, lung, brain, like the things that are the average dosimetrist should be able to contour pretty quickly. These things will do a very good job of contouring. The things that it will usually struggle with, abdomen, pretty much all of the small bowel and things like this. I mean, a lot of people will just end up using a bowel bag and lumping all of that together. It doesn't always do a very good job with some of the vessels in the abdomen. It gets confused with other density materials. So I think it's always good, no matter what, even if you're going to use an automatic contouring tool, always double check the contours. Make sure that the computer did what you expected it to do. Don't make any assumptions that it's doing a good job every time. I always double check. Computers aren't as smart as we think they are at times. So
surely that is very, very true, actually. That is very true, Doctor.
I think if the computer could do a really good job, we'd all be unemployed very quickly, right? So as long as computers make mistakes, we have things to do, right? So
in our center, I remember one day, one plan, the AI contoured the small bowels as a rectum. I remember. So there's those small errors that you need to really keep an eye on, and yeah, always double check before you proceed. So it's very key.
So I did want to touch on this. Usually when you're done with the contours, it's good to define these interest points, POIs, sometimes they're called 2 points of interest on the CT scan. And so this is where you would define an isocenter, and this is the point at which all the beams would be centered on. And the other one is on this slide, it's labeled origin point. We also call it like a localization point, the point that you set up the patient to. Most planning systems will output some sort of shift information from your localization point to your isocenter. So like in this case here, you can see this patient has a 3-point BB. This is probably put on the vac fix on the side. That's why it's out in the air. And there's another one hidden over here behind the word session. But so that's our localization point, origin point, and that's where the BBs are. And you can see, obviously, by having the BBs on the scan, I move these planes over that point, and then I'll add the point there. It's pretty straightforward. Isocenter, in the case of that spine that we had contoured, I would usually put isocenter in the target. Does the isocenter need to be in the target? Not necessarily, but I think it's good practice, at least for beam weighting and planning and design. It's good. There might be instances, for example, where like I'm going to treat a vertebral body, but I may in the future have to retreat that patient again because there's metastatic disease in the vertebral body, and I don't want to have the beam divergence to deal with if I have to come back and treat it. So I might put the isocenter in between two vertebral bodies, and then I'll treat one superior so that in the future, if I have to come back and treat the inferior one, I don't have to accidentally worry about treating the cord too much with the diverging beams. So there's some logic that can be used in identifying where I put these isocenters. But in general, too, you want to make sure that wherever you put isocenter, that you don't end up having the gantry run into the patient, right? So if I put the isocenter and it's a larger patient and I put isocenter here, I might not be able to get a beam from the other side if isocenter is located too far laterally. So just be cognizant of where you're going to do that. And then it's also good to, we like to document in notes all of the immobilization devices, and then we put the shifts, and we'll say, okay, now this is the shift with respect to isocenter within the patient. So 1 cm right, you would, in this case, the isocenter would be moving into this direction. And then if you're going to move it posterior, then you'll see that you'll move the isocenter. The isocenter is going to go post, so you'll be moving the patient in the opposite direction. But these notes we usually generate at the time of treatment planning, and this is the notes that the therapists do. I would say this is very helpful. Our dosimetrists like to tell the therapist what the TSD is, and they'll use the optical distance indicator on the LINAC to see on the skin surface. Like I'll double check that TSD is matching given the shift that they gave me, so I don't make any big gross errors. So they'll usually give like an AP and a lateral TSD that gets put in the note. So that's very helpful for the therapist to help set things up. And some sites we'll have a dosimetrist come out just to make sure that the patient's setting up properly as they planned, which can be helpful if your dosimetrists have the time to do that. So I think we made it through all the material from 3D imaging and limitations there, importing it, assigning the CT to ED, defining the volumes that we're going to use to calculate dose within, registering our ancillary images and fusing them, defining those targets and organs at risk, and then setting up these isocenters and the shifts that the therapists are going to need. So I think we've covered most of our bases up until now, the point where dosimetry is going to start treatment planning. And the order can vary a little bit from place to place. Like you could actually start doing all of these items here without this. Like oftentimes our dosimetrist will grab the CT scan, they'll import it, they'll set this volume, they'll start contouring organs at risk and this, and then the physician will, maybe a couple of days later, diagnostic radiology will get that MR, and then they'll send it over. So they'll add this later, and then the physician will add the the targets after the fact. So there's no reason some of this work can't continue on. The order doesn't necessarily, this particular step could be changed. You could also, I personally like to put these points on right away, even before I start contouring. So I usually do that up here when I assign the electron density and put the couch in. For me, it's just sort of basic maintenance, and it's all in the same general area in the planning system, so I get it done up front. So I wanted to put these references. This is report 83. This is actually TG 66 from AAPM, the quality assurance for the CT simulator. I think this is good for physics to follow, and it gives a lot of good general information on the machine. The other one is the TG 53. This is quality assurance for treatment planning. But I think a lot of these, there's some overlap in here, especially with the CD to ED file collection and some of the things that you should probably check. Do some end-to-end testing when you bring in CT scans into your planning system to make sure that you understand how one system impacts the other. So yeah, this is, I should have put it in here, but this is TG 66 is this top one here. So with that, I'm done. I think I apologize for going over on time, but I'm glad we had a lot of questions here.